Hello from Budapest. We are very pleased to have you on this eCancer review of debates, a meeting that is ongoing as we speak here in Budapest. Interestingly enough, we are in one of the most beautiful venues in the world, but we are in this room ready to discuss genitourinary malignancies. And I am here with esteemed colleagues that I will let actually introduce themselves. So Thomas.
Thomas Steuber. I'm a urologist working in the Martini Clinic Prostate Cancer Center at the University Hospital in Hamburg, Germany.
I'm Peter Goebell, urologist from the University of Erlangen in Germany, southern Germany, Franconia to be precise, and I'm leading the study unit there.
Joaquim Bellmunt. I'm a medical oncologist, mainly dedicated to bladder and prostate cancer. I'm a professor at Harvard Medical School and also presently directing the IMIM Institute in Barcelona.
Gentlemen, I actually need to introduce myself. I'm Eleni Efstathiou. I'm a medical oncologist as well, focused mainly in prostate cancer. And I am Greek, so I do still have affiliations with Greece. But it's very interesting. The Germans are still in place, but the Spaniard and the Greeks have moved over to the United States. Political comment here. So, moving on, we've had a great session yesterday, and we're going to have an even more interesting today. But I wanted your views, since we are a mixed group, we do have urology, strong presence with a lot of interesting data coming from Germany in advanced imaging, how to do better for our patients, and medical oncology, of course. Sometimes we are more conservative as medical oncologists. So I wanted your view first on a more kind of bigger picture topic. Joaquim, yesterday you had a very interesting session on a holistic management for all types of GU cancers. Can you give us some take-home messages? And then Peter and Thomas, your views on the holistic management.
Yeah, so the first session, the title, as you mentioned, was Holistic Management, and I explained to the audience, holistic doesn't mean religious or magical way of treating patients. Holistic means treating the patient as a whole. And in this first session, what we discussed mainly was comorbidities and the geriatric assessment. Then we focus on bone health, and in the end, on polypharmacy. So those are things that we are all the times facing when treating GU patients. And I think it was a really interesting discussions presenting the way that you need to, let's say, score a patient in terms of comorbidities or geriatric assessment using the G8 score, and the way that this can be implemented in daily clinical practice. We jumped then on the way to prevent bone loss, and the interesting thing was it was not only for prostate cancer. We moved the topic to bladder, and we know that bladder patients are receiving neoadjuvant chemotherapy, and also the bone loss is more and more important. And then polypharmacy was given by a pharmacist, and it's really something that we need to keep in mind because these patients are an age patient population, taking a lot of medications, and the interactions with the other active treatments that we're giving are really relevant.
So Peter, I mean, at the end of the day, I think we're all busy in our clinics. Do you actually take the time to do the geriatric assessment, or do you?
We do.
You do?
Actually, there's it's called the Erlangen score. We actually evaluated all these different geriatric assessment scores, and we figured out that they are not equal. And we made up actually a new score. One of our colleagues is working on this. It's shorter than all the different other assessments. B, it's easier to provide, and we saw in the retrospective analysis that this is even superior, for example, to predict perioperative morbidity, for example, and so we actually evaluate each and every patient who's above 70 with this score.
Very, very good point. Thomas, does it affect your practice?
Yeah, I think it's a good way, or it's easy to handle when you use it. It's a quick job. I mean, it takes less than 5 minutes, and the patients can fill it themselves because the questions are quite easy about their daily life. If you have a score above 14, it's straightforward because you can consider him being fit for any systemic treatment. If he is like frail and to decide whether it's reversible or not. I think it's getting more complicated because you need a backup of a geriatric, you need internal medicine, so then it becomes more multidisciplinary. So you have to have a good network that you get the feedback, and you will see the patient again to eventually assess whether he is amenable for systemic treatment or not.
So this was a good point. I think the important point for everyone who's watching is the assessment allows you to consult with others who are more specialists, and it doesn't add time. It actually takes less time at the end of the day, and you avoid the complications that may ensue if you have all the parties involved from the beginning. So this is the most important part of the holistic, which, by the way, I didn't think that people would perceive, as you said, Joaquim, because, you know, being a Greek word, I was like, thought it was straightforward, but great point. So, and of course, I'll move quickly to something that's dear to our heart, Thomas, which is prostate cancer treatment. And I wanted your view. Yesterday there were two sessions, one on hormone-naïve prostate cancer, and one on the next topic that you two are very interested in, early castration resistance. So I want to start, because of the natural history of the disease, with hormone-naïve prostate cancer and the explosion of data that's coming through. And your thoughts, Thomas, how is it shifting and changing treatment paradigm for prostate cancer? Yesterday there were concerns, for instance, if you use all these agents early, and you know my views on that, you're not going to have them later. Would you like to comment on all these thoughts?
No, I don't agree, because if you look at the tremendous overall survival benefit when you use early chemotherapy or you use early abiraterone, the patient benefits. I think the discussion at the moment is more complicated to see or to decide which drug to start, and it's going to be even more complicated. Probably other potential drugs are going to move into this field as well. There are ongoing trials, and we will in future talk about even more intensive treatment, so adding chemotherapy and abiraterone in the setting of a hormone-naïve metastatic cancer. So they are also running trials there, and to make it even more complicated, the role of local treatment. So I think the biggest shift of paradigm is happening in the hormone-sensitive metastatic setting. I think the steps of advance in the castration-resistant, it's very hard to reach further survival, but in the beginning it counts.
But I think that the next big step is going to be high-risk localized disease, right?
Probably.
We need to tackle it at some point.
Definitely.
And you two, as urologists, I know, have a great interest in that. But I wanted to ask you, Joaquim, do you think we are reaching a time where prostate cancer is closer to breast cancer therapeutics with the advent of agents earlier, or are we still far off?
I think that's a funny question. So despite the high incidence of prostate cancer, we have been lagging behind breast cancer, where the field of managing patients with hormonal therapy, chemotherapy has advanced so quickly. And in fact, if we see that we are moving in the same direction, introducing earlier and earlier chemotherapy, different type of hormonal therapies. So it looks like, so we are getting
but
there.
no biomarkers.
Yeah, that's a critical issue, but maybe we are going to get some in the future.
So quite hopeful. And with that, I mean, we're not there yet fully with hormone-naïve, but Peter, as we were preparing for this session, you expressed your interest in this continuum of castration resistance. There's been an explosion within 1 year of 3 trials, and I bet there's going to be more conflict moving on how we're going to best select the right agent. For practical considerations, we have 3 novel anti-androgens of the second generation that are showing powerful data, and in fact, it's a triplicate. 3 trials showing precisely the same data. How do you view this shift, and how do you think it's going to contribute to a better treatment of those men who are now feeling androgen deprivation as we know it?
I think that these trials clearly show that combination therapy is probably the way we are moving forward. So there are two two or three messages in there. The first message I think is that ADT alone is, as we've seen in hormone-sensitive treatment, high-risk patients, combinations are earlier and earlier, and I think what we are seeing there is that combinations is probably the way to go. So ADT alone is no longer the standard. I think it is more towards combinations. And we see the same also in the field of castration resistance or early castration resistant, even in the non-metastatic, an interesting question whether that exists, non-metastatic but castration-resistant rising PSA patients, and even there we see the combinations. And as you said, new drugs there, enzalutamide, darolutamide, and apalutamide as possible options. There are three really convincing trials leading to a delay, actually, of measurable disease. Of almost 2 years, and that's a huge progress. What it tells us is, combinations and early combinations, also in this settings, are relevant for the patients. It may delay progression for these patients. It actually showed also that there is an overall survival benefit, independent of all consecutive therapies. And the third part, I think, is very important because it was a gray zone in the past. We were searching for all these METs. We were thinking they are there. So PSMA testing, for example, is a huge topic, actually, to really find out what is the disease, what is the status of the disease, irrespectively of the rising PSA.
Very, very interesting point. Now, we've got the 3 trials, positive primary outcomes of delay in metastases, great data on quality of life, great data at least to understand better safety and try to overcome it and pick the patients. But you brought up the point of that continuum being disrupted as it was defined in the past, structurally defined, as Matt Smith said, with regard to whether it's metastatic, non-metastatic by just conventional imaging. And yesterday you made some comments about what he brought up just now, PSMA or other advanced imaging. Does it really make a difference in the biggest continuum, or should we just rely PSA doubling time, high PSA at baseline, and you're good to go? What do you recommend?
No, I think it's crucial, as you mentioned, to really identify the patient based on the high-risk definition. So precisely calculate the doubling time, look at the PSA level, because you may have a very indolent course of the disease if you have a low PSA doublet time.
So you wouldn't treat that?
Those patients won't need treatment, or maybe you can treatment with vintage drugs like bicalutamide, flutamide, whatever.
So you still use those?
Yeah, why not in this? Because they are
it's more emotional.
They're worried. No, they're worried because of the rising PSA.
Patient, yeah.
So, but if it comes then to a high risk, like a rapid doubling time, I would order conventional imaging. I would not seek for the metastasis.
Even though you're the gurus of advanced imaging in Germany.
Yeah, but I mean, still in Germany it's not reimbursed. So I would.
It is not.
Yes, no. It's just the private insurance that cover it, and some public insurance. But the vast majority doesn't have access to PSMA PET scan, and the prices is in about 1,018 to 2,500 euro. So still expensive.
Oh wow.
So what do we do with a lesion that is invisible in conventional imaging but visible in the PET scan?
That's a big question that we need to try.
So I avoid the conflict. I mean, in this setting we have perfect drugs. They work. They delay metastasis and even symptomatic progression. I think that's a good endpoint.